But today we're going to talk about surgical treatment of hyperacusis. And I just wanted to, before I start talking about it, just tell you a little story how this all happened. So in 2010, a patient came in to see me that had been involved in a bad accident where a tank of gas blew up in front of the person and blew out the eardrum on one side, and he developed noise intolerance or hyperacusis in the other ear. And he said, "Doc, what can you do to fix this? Because I can't stand being around any kind of noise. I have to go and be in a quiet room all the time. And, this is affecting my life." So I said, "Well, I'm not sure. I've never seen a patient have this before, but why don't we try, if you want to let us try something, we could try to put some tissue in beneath your eardrum to try to dampen the sound waves going into your ear, and maybe that'll help you." And we did that, and lo and behold, the patient was cured of his problem. And so the next patient I saw was 4 years later. But I'll begin my lecture now and tell you this, how we got to where we are now. This is our office. We've been in here since 2003. And I don't have any financial relationships to disclose. And I just wanted to tell you a little bit about hypersensitivity to sound. There are actually 4 different types: hyperacusis, recruitment, misophonia, and phonophobia. Hyperacusis is a condition where a person cannot tolerate normal sounds. They become very anxious and avoid places like movies, restaurants, and sporting events and concerts. It often affects their quality of life, and they become recluse and stay in their house or their bedroom. Evidently, this affects 6 to 17% of the population. These patients can have normal hearing or some sensory neural hearing loss, nerve loss, and their uncomfortable loudness level is below 90 decibels. Now, you and I can stand 90 decibels to 100 decibels without too much difficulty. But these people have a lot of trouble when it gets below 90 dB. Tinnitus is often associated with the hyperacusis. And the treatments are wearing earplugs, tinnitus retraining therapy, cognitive therapy. Long-term treatment is usually required, and the results are variable and may not be very effective. Recruitment is a sudden marked increase in sound that occurs when noise level reaches the patient's hearing threshold. These patients usually have some hearing loss, and they commonly have Meniere's disease or too much pressure in the inner ear. And the treatment is with TRT, the same as hyperacusis. Misophonia is a reaction or irritation to certain sounds like dripping water, chewing, pencil tapping, or chalk on a chalkboard. Phonophobia is a fear of sound. In those patients, usually their LDL or their loudness discomfort level is normal, and they need psychotherapy. The causes of hyperacusis are often unknown, but head injury or a noise trauma to the ear occurs in 62% of the patients. They can have cochlear trauma, superior semicircular canal dehiscence, which is a loss of bone over one of the canals, a perilymph fistula or leakage of fluid from the inner ear. They could have adverse reaction to certain medications. And recently we found out that the little stapes bone, the third bone of hearing, can be loose in the oval window, and this may be caused the hyperacusis. The possible mechanisms are impaired neuroplasticity in noise suppression. So essentially the brain suppresses the noise that you hear, and that it's not working well in these patients. they could have hypersensitivity of the cochlea to sound or hypomobility of the stapes. So the possible hypermobility of the stapes or hypersensitivity of the cochlea to sound could be reduced by putting some tissue against the round and oval windows to reduce the sound vibration, reducing the symptoms. And we researched the literature when we first started doing this, and we only found one case of a reported case of a patient with superior semicircular canal dehiscence that had round window closure with relief of symptoms. And there were no previous literature reporting this procedure. So the first patient I told you about when I first started talking, and this was the first patient that we saw that had the explosion and did well after temporalis fascia was placed in the middle ear, which blocked the sound waves. And this has lasted up till the present time. This is a picture showing the temporalis fascia over the stapes bone and the round window. The second patient occurred 4 years later. This patient came in complaining of the hyperacusis that she's had for years. It impacted her quality of life. She had to avoid noisy places. And I told her about what we had done 4 years before, and if she wanted to try, she was willing to try to see if the temporalis fascia reinforcement would work. And the right ear was done first, and she was so excited and happy about it that we did the left ear soon afterwards. And this improved her quality of life, and she's been very happy ever since. So the way we do the surgery is we take some fascia or tissue from over the muscle above your ear, and we use a dermatologic punch and make little round circles of the fascia of 2 millimeters in size, and then several 4 millimeters in size. This is going to show you a video of the round and oval window reinforcement with temporalis fascia. Let's see this right here. So this is a patient that had hypermobility of the stapes. And you can see we're pressing on the stapes now. You can see how loose the stapes is. It should not be moving like this. This is very abnormal. And this was the first patient that we decided to add more tissue into the to reinforce the windows. We also took electrical stimulation, and you can see the little stapedius tendon contracting and the stapes moving when we're stimulating the cordotympany nerve. So after we played the tissue around the stapes and the oval window, you can see pressing on the stapes now, and the incus gives much less movement. And this patient was very happy with the result. And this was the first patient that we used to add more tissue to the ear. And it found that it did help the patient's symptoms. Here we're stimulating again, showing that there's very little movement of the stapedius tendon. So then the purpose of our study has been to evaluate the effect of round and oval window reinforcement in reducing the symptoms of hyperacusis. And it was a prospective study. We have 80 patients now over the age of 18 years of age, and it had an IRB approval. And we did a hearing test and an LDL, loudness discomfort test, before and after the surgery. We did a CT scan of the temporal bones to rule out perilymph fistula and superior canal, semicircular canal fistula. They filled out a Hyperacusis questionnaire, and they marked their severity from 1 to 10 10 being the most severe. And they also took a GBI, or a Glasgow Benefit Inventory, post-op to see how they did from this procedure. So the GBI is done after a medical intervention to discern the general health status of the patient, the physical health status, and the psychosocial health status, and their social report. So we did the testing before surgery, and 1 week after surgery, 4 weeks, and then 52 weeks after the surgery. So here, showing the round window being reinforced with several pieces of temporalis fascia, and then we put the 4mm piece over that. This is a little piece of gel foam to hold the tissue in place. And this shows putting the little 2mm pieces around the stapes bone. We usually use 10 pieces of temporalis fascia around the stapes to reinforce it. This shows some more tissue being placed around the oval window. So we divided the patients into 2 loudness discomfort groups. 52 patients, the LDL group was above 70 dB. So we call those moderate discomfort to sound. So they were between 70 and 90. And then 21 patients had very severe hyperacusis, and their LDL was below 70 dB, and they were called high discomfort to sound. So the post-op improvement in the moderate discomfort group, that is the ones with LDLs above 70 dB, was 81%, and they would recommend the surgery to other people. And 72 or 73% stated that the improvement lasted for a long period of time, from 1 to 6 years. In the high discomfort group, where the LDLs were below 70 dB, only about 50% would recommend the surgery. So because of the results, we decided that we were going to do another study and enhance the reinforcement of the round and oval window, especially in those patients that had high sensitivity to sound. So after we put the 10 pieces of temporalis fascia in, we put another 4mm piece of fascia over the stapes and draped it like a tent over the incus and the stapes. And then we took another piece of fascia, 6mm piece, and placed it beneath the eardrum to reinforce the eardrum. Now we've done 7 patients now, and all the patients have had an improvement in their LDLs. This patient had an LDL of 65, which is very severe, pre-op, and post-op went to 95 decibel, and this patient was very, very happy. So in these patients where we're using the enhanced amount of tissue, we're getting better results, and we feel that that we're in an area now that we can increase the success rate greatly by adding more tissue and enhancing the round oval window reinforcement. At the time of this talk, we had 4 or 5 patients. We've done 3 or 4 more patients. Then they've all had good results, except for one patient said they're having trouble hearing, but this patient has a sensory neural hearing loss and did say that the sound intensity was much less. And that patient, the LDL went from 60 to 90. So it is working with the extra tissue. 3 patients stated that the surgery prevented their committing suicide, which I think is very significant. The other thing that has happened is the unoperated ear may improve. And so the second ear may not need surgery if it is not severely affected by the hyperacusis. And tinnitus, unfortunately, was not changed in any of these patients. So the LDL is a good predictor of possible success of the round and oval window reinforcement surgery. Those with the pre-op LDL 70 dB or greater have an 81% chance of improvement, and those with the pre-op LDL have less than 70 dB have about 50% chance of improvement. And that was before we started adding the extra enhanced amount of tissue. And we've done 7 patients now, and every patient has had an improvement in their LDLs. And I think that the bottom line of all this is that the more tissue you can put in to a certain extent that would not cause hearing loss, the better the result you get. So patients do better with more tissue reinforcement and adding a graft to the tympanic membrane. Thank you. So I'll open up the discussion to questions.
I had 2 questions. My LDL is probably at about 70. I've had it for 4 years. I've also had like vertigo off and on, but I haven't been diagnosed with Meniere's because I don't have any hearing loss. But I do, when my flare up was original, I did have really bad fullness in the ears. Is that like, do you have some people that did not have Meniere's but had hyperacusis and fullness in the ears, and the surgery helped them?
Yeah, so this is a little different. This is the recruitment that I was talking about.
Yeah.
If you have episodes of vertigo and pressure and fullness in the ear, it's probably due to increased pressure in the inner ear or Meniere's disease.
Mm-hmm.
And in that case, what happens is the hyperacusis is really recruitment, and what happens is that when the sound gets to the level of the hearing loss, suddenly the whole inner ear is activated and you hear the sound very loud.
Okay.
But that's not going to be helped by the surgery. The surgery is only for patients with hyperacusis.
Okay.
And if the patient has a lot of other problems along with the hyperacusis, and hyperacusis is really not a major problem for them, then we would not do the surgery because it's not going to affect their quality of life if they have a lot of other problems along with hyperacusis.
I haven't had the vertigo for years. It's just the hyperacusis and tinnitus that I have now, that for the 4 years. So
you should have a hearing test.
Okay.
And an LDL. What is your LDL now?
If I had to guess, I'm going to say at around 70.
Right. So you would be a good candidate for the procedure then.
Okay. And my other question is, how do you secure the tissue in there? That's just a scientific curiosity.
How did I miss that?
Like when you put the tissue into, I'm not using the right medical term, but when you put the tissue into the ear, how does it stay in place? I'm curious.
Oh, good question. So what we do is we scratch the bone of the ear to make it bleed a little bit. Okay. And so we've had one patient recently that we did a revision on, and the tissue is still there. It was 3 or 4 years later. So the tissue does heal to the bone there, and it stays in place.
Okay, thank you so much.
All right.
There's another question. How many layers are placed of the tissue?
Right. So in the original series, we just did 3 pieces of tissue on the round window with 1 little piece of tissue on the stapes. We did that for 2.5, 3 years until we found a patient with the hypermobile stapes. Then we started another series of patients putting 10 pieces of that 2 millimeter pieces around the stapes and 2 millimeter pieces on the round window with a 4 millimeter piece over that. And those cases were the ones that we reported here. And so we've done that for about 3 or 4 years. And then now we're doing this enhanced amount of tissue. And so that after we put the 10 pieces in, we add another 4 millimeter piece over the incus and drape it like a tent over the incus bone, and also reinforce the eardrum with another piece of tissue. And that seems to work very well and give us the best results so far.
And the other question with that is the tissue in front or behind the eardrum?
We lift the eardrum up like a book. Actually, we lift the eardrum up and we're looking inside, like you're looking inside a book. And you put the tissue inside behind the eardrum. So if you look at it, you could think of it as wearing an earplug inside your ear instead of the earplug on the outside. And because it's in there permanently, it stays there and it works better than just the earplugs. And we haven't had any patient ask to take it out, take out the tissue. If it doesn't work, it means that the problem is caused by a central problem, probably in your brain, and that surgery is not going to help reduce the hyperacusis. Unfortunately, it's not a lot of patients that are like that.
Okay, the next question is for patients that are in Europe. What do you suggest as far as doctors having this procedure?
That's a difficult one. We've had several patients come from Europe to have the surgery, and it's not difficult surgery, and we've written 5 papers in the literature on this, and the procedure is shown on the internet also. So an ear surgeon who is interested in this could do it in Europe. But they would have to be interested in doing this kind of surgery.
The next question is, what is the lowest dBl you would operate?
I think we would operate on, we've operated on them as low as 40 decibels. And I think the LDL test is not a very accurate test. And one day it may be 140, the next day it may be 60, depending upon how the patient feels and how they react to sound. So I think that we really don't use that as a criteria to operate or not operate. It's really on the patient's symptoms and how much it's bothering them.
Okay, the next question is, if I have hyperacusis and can feel vibration from a lawnmower or drums, would you think it's still hyperacusis that they have? If they can feel noise vibration?
I'm not sure about that. If they can, I haven't heard many patients complain of that with the hyperacusis, that they can hear the vibration. I have a lot of patients that complain of pain with the hyperacusis, and that seems to be helped by the surgery almost every time.
Okay, the next question is, you mentioned semicircular canal abscess being ruled out by CAT scan prior to surgery.
Right.
I have heard semicircular canal dehiscence as a cause for hyperacusis, but patients cannot get MRI due to pain from the loudness of the MRI.
Oh, well.
Do you rule this out or explore fix during your surgery?
They don't need to have an MRI. The CT scan will show the fistula, and you do the same procedure. You'd still put the oval, the round window reinforcement and the oval window reinforcement, even if they have a superior canal fistula.
Okay, the next question. I guess, how do you determine and know in advance prior to surgery if the hyperacusis comes from the brain?
Very difficult. The only way to tell that is to see if the patient has other symptoms that are going along with the hyperacusis. And if they have psychological problems and other problems, it may not be due to just the ear, and putting tissue in may not help the patient. But I don't think you can tell in most cases until you do the surgery.
And the next question is the date of the latest research paper on hyperacusis.
You would have that.
It's very recent. I just have to look up the exact date.
Yeah, it's. I think it was a few months.
It was in the beginning of this year.
Beginning of this year. Yeah, it's in the American Journal of Otolaryngology.
We also have it listed, the date and title on the website. And
it's on the website too, on our website.
So do you operate also on pain hyperacusis or only loudness hyperacusis?
No, pain hyperacusis is affected very well by the surgery. For some reason, and I don't understand why, the pain goes away, but almost in every case, the pain goes away after doing the surgery.
Okay, the next question is, can a person have recruitment and hyperacusis? I have hearing loss and low frequencies, but high frequencies are also very loud. This all comes from an MRI.
If you have a low frequency hearing loss, it's probably due to high drops or Meniere's disease, and that's what's causing the recruitment. And I think that it's probably recruitment rather than the hyperacusis. I haven't seen any patients that have had both together. It's either one or the other.
Are you able to see on an MRI the semicircular canal abscess?
The MRI, we use the CT scan to see the semicircular canal dehiscence. It can be seen on the MRI, but we use that. And CT is much easier to get, and it shows it very nicely.
How many layers are placed on the new eardrum patching?
One layer of temporalis fascia is placed beneath the eardrum.
Is the surgery reversible if it didn't work for someone?
I'm not sure about that. It would be reversible if it was done, if it was reversed soon after the operation, but after the healing occurs months later, it would be difficult to get the tissue out because it grows to the bone and to the little bones of hearing.
So if somebody were to travel here for surgery from Europe, is there a time frame that they wouldn't be able to fly after surgery?
Yeah, they stay here a week. We've had patients come in from Europe and they stay here a week, about 10 days. They come here on a Wednesday, get operated Friday, and usually can leave the following Wednesday or Thursday.
Someone is asking about the use of, I'm probably saying this wrong, clomipramine drug.
Botox, is that?
Clomipramine?
I
CLOMIPRAMINE.
I don't know about that.
Clomipramine, it's a TCA. It's an antidepressant they use for the treatment of hyperacusis as a drug. It numbs the nerve.
Yeah, well, I'm not familiar with that, but recently from Europe, I got a letter that some doctors are injecting the tensor valli palatini muscle in the mouth with Botox, and they say they paralyze the tensor tympani muscle and tendon, and that helps the hyperacusis. And I don't understand that at all, because I would think that doing that by paralyzing the tendon that's holding the bones from vibrating, that if they weren't working, they would be worse hyperacusis. So I'm not sure about that, but somebody has written to me about that procedure.
Are there any other questions?
Has anybody reported that they can feel the tissue in their ear after?
No,
Oh, that's good.
no. No, we do tympanoplasties, repair eardrums and the little bones of hearing, and nobody ever complains of that.
If hyperacusis is a damage inside of your ear, like what is the theory as to what's happening inside the ear? Like,
Well,
I know there's like your theory for this surgery is the stapes, right?
there's
Yeah.
I told you there was three possible mechanisms
Oh, right.
that
Okay.
the brain is not suppressing the sound waves
Mm.
going into your ear, that the cochlea is hypersensitive to sound,
Mm-hmm.
and that the stapes is moving too much. So there's
Okay.
several different ways that it could be occurring.
But and one more question. In your opinion, I know this is a theory, but if you have pain hyperacusis, could it still be the brain? Or do you think that must be the ear if you feel pain?
That's a good question, but all I can tell you is that almost every patient that had pain did not have pain after the surgery.
Okay, that's great. Thank you.
The next question is, can the operation make the hyperacusis worse, and what are the risks of the operation?
Very good question. So the risk of operating on the ear is causing more hearing loss, having an infection in the ear post-op, and affecting the chorda tympani nerve, which is that nerve of taste that runs right across where we're operating. If the nerve is touched or stretched, there may be a taste disturbance for several months after the surgery. We haven't seen that happen in any of our cases. We did in the first, we had one case that had taste disturbance. The other possible complication that it doesn't work, that's not a complication, but that it doesn't help. And as far as making the hyperacusis worse, I haven't seen that. It either doesn't help or it helps.
The next question is, does the tissue last a lifetime?
I think it probably does. The one case that we revised and went in to put more tissue in, the original amount of tissue was there and had grown to the bones of hearing and the round window.
Would you do both ears at once?
No.
Or you have to do separately?
No, we
How
never do two ears at once, for fear that something bad could happen to both ears. And also you want to see how the patient reacts to the surgery on one ear and get that ear as good as you can before you do the second ear, because you may even not have to do the second ear.
And then approximately how much are the surgery costs?
It's about $10,000. Insurance usually covers it, and most of the expenses for the hospital and the anesthesia.
Any other questions? Why would the second non-operated ear improve after the first?
You're asking questions that I don't understand or have an answer for. That's a good question, but we think that the fact that the sound waves going into the brain are reduced, that it affects the opposite ear also, that it acts to help decrease the sound coming from the other ear. But we don't know that. And we don't know about what causes the pain in the ear either. That's another one questionable question that we haven't been able to answer.
Are there any other options for recruitment?
Not that I know of.
Any other questions?
Yes, I would like to know, is there a way to get a consultation with Dr. Silverstein?
Yes. Yes, it's very easy. You can, we do telemedicine all the time. And what we like to see is a hearing test and an LDL test done by your audiologist. And if you can get a CT of the temporal bones, that's fine. If not, we'll order it. And then what happens is you call and make an appointment, and we do it by video.
I'm putting the phone number in the chat right now to make an appointment.
Right.
Thank you very much. I've talked to one other doctor in the group, and I would like Dr. Silverstein to please review my case.
Sure. So let me explain how this works now. So the surgery is actually done by Dr. Nyack, and I'm at the operating room supervising and coaching this surgery to make sure it's done right. And that's how we've been doing it for the last couple of years.
Okay, yes, thank you. I'm the one that can feel some vibration, but
Right.
I don't like the drums or the lower has to be close to me.
I think it would work. I think it may work.
Wonderful. Okay. I'm getting that temporal scan to rule out some other inner ear issues.
Right.
But I'll have another consult with him then. Thank you, sir.
We've done 80 cases now and about 100 ears.
The next question is tinnitus louder after the surgery?
Some patients have had, a few patients have had worse tinnitus after the surgery. But that's been pretty rare. Most patients have, like I said, they're either the same as they were before surgery or that it helps them.
I don't think there's any other questions.
Okay, great. Okay, if you want to make an appointment or talk more about it, it's very easy to call and make an appointment for a web Zoom type of consultation. And
I just put the phone number in the chat for everyone.
Okay, great. Okay, thank you.
All right, thank you.